Welcome to Union Community Health Center's Grand Round Series. Today we have a very special presentation where we will introduce you to osteopathic manipulation treatment, a very unique specialty we have here for you at Union Community Health Center. And we're very excited to have an introduction to OMM. This is a very special presentation because we are one of the few FQHCs that have the opportunity to have osteopathic manipulation medicine. So this is something for all of us to learn about. I know in medical school I didn't really learn much about OMM, and many of us might not know too much about it. So this is a great opportunity to learn about the different services we have for our patients. So with great pleasure, I have the introduction of Dr. Ruba Katrajian. Thank you.
Thank you, Dr. Salcedo, and thank you everyone for joining us today. I know this is your precious lunch hour and how much that means. So to get to it, we're just going to do an overview of what osteopathic medicine is today, a little bit of history, philosophy, what it can help, how does it work, and what to expect during a visit. At the end, I'm briefly going to touch on trigger points because I do those as well. So in the US, there are two schools of medicine, MDs and DOs, or allopathic and osteopathic, respectively. They hold equivalent degrees and undergo the same levels of licensure and certification, so they can enter into any medical specialty, including OB, Peds, IM, family, etc. The difference is that in an osteopathic school, the emphasis is placed on more of a primary care holistic view of the body. And I know that this is also changing in MD schools where they're encouraging this as well. We also get hands-on training to learn how to diagnose and treat with our hands. So that's what osteopathic manipulative medicine or treatment is, or OMM or OMT for short. It's defined by the American Osteopathic Association as a hands-on, whole-body approach to diagnose, treat, and prevent illness or injury, during which the osteopathic physician moves muscles and joints using techniques including stretching, gentle pressure, and resistance. People who continue to specialize in these skills become OMM specialists. So what is the core philosophy? It's composed of these four tenets, which are the body has an inherent ability to heal itself, structure and function are interrelated, the body functions as a unit, and a rational approach to healthcare applies these principles. We're going to briefly go through each of these just to give you an example. Okay, so the first one, the body has an inherent ability to heal. It's pretty self-explanatory. I think it's sometimes things that we take for granted, our ability to heal from a cut, scrape, wound, abrasion, simple fractures that don't require any surgical intervention, or even the regular day-to-day pathogens that our bodies are inundated with, right? You build an immune response, you're able to fight it off. Sometimes you get a little bit of a cold or a flu symptom, but overall, your body's able to take care of it, get you better, and move past it. It's once that we've overwhelmed our system with a more severe injury or illness, that's when we need to step in with antibiotics, surgeries, or other interventions, medications, procedures to help the process. The second tenet is structure and function are interrelated. The perfect example of this is something called piriformis syndrome, where you have a structural issue, a spasm piriformis muscle, causing an irritation around the sciatic nerve, which in a certain percentage of people actually runs through the muscle instead of under it or around it. And that can lead to symptoms of sciatica that are not being propagated in the lumbar spine, but lower down in your buttock area. And so numbness, tingling, weakness, pain, radiation, irritation, all of these things could be ameliorated by treating out the spasm in the piriformis muscle. So again, the structure is impaired, it impairs the function, you relieve the issue in the structure, and it improves the function. Number 3 is the body functions as a unit. Another pretty self-evident one, right? We have our nervous system seen in the middle of this slide. We have our circulatory system seen to the right here. We have our skeleton, our muscles, everything that attaches to it. And within there, we have our organ systems. And if we had each of these as standalone systems, it wouldn't work, right? You would be a pile of bones on the floor if you didn't have the muscles and fascia and tendons to hold you up. If you didn't have functioning nerves, your muscles wouldn't be able to respond to anything. If you didn't have the circulation to provide the nutrition to your muscles, they would also atrophy and die. So without looking at it as a big picture, we sort of can miss the forest or the trees and how that applies to our overall health. The fourth tenet is a rational approach to healthcare applies these principles. So an example is, of course, if you have low back pain due to a muscle spasm, you don't jump to doing surgery. You don't jump to discectomy to treat the issue. It's rational to try OMT, PT, NSAIDs, muscle relaxers, etc., to improve the problem. However, if you have an issue like biliary pain due to cholelithiasis, the stones in the gallbladder, that are causing a structural issue by blocking the duct, it can lead to infection and inflammation, and ultimately the most rational way to treat this is to remove the gallbladder. So really it's just common sense. How do you apply what's going on in the appropriate way to each individual situation? So now we're going to go through a little bit of the history as to how osteopathic medicine got to where it is. It was started back in the 1800s by an MD physician by the name of Dr. Andrew Taylor Still, who was on the frontier in the mid-1800s. He unfortunately lost his faith in the medicine at the time because of losing 3 of his children to meningitis and 1 to pneumonia. And the medical care at the time was just not good. We didn't have good quality antibiotics or procedures to help. And so he underwent study of anatomy and physiology to understand better the functions of the body. And he found that anatomical deviations impaired blood flow, nerve function, leading to disease processes. And if you were able to correct these, it allowed the body to restore normal function and could get better from certain things. So he tested this theory out for decades. He opened the first school in 1892, and this was in Kirksville, Missouri. Since then, the profession has grown considerably. We now have 37 accredited osteopathic schools. 26% of medical students are DOs, and there's 134, almost 35,000 practicing DOs in the country. Okay, so what does it do? What can it help? This is not an exhaustive list of problems that might be helped with osteopathic treatment. These are just some of the more common ones that we sometimes see. The biggest of these is that first chunk, the musculoskeletal list, including neck and back pain. I don't know anyone who's not had at some point or another in their lives some kind of neck or back pain. And this can include disc disease, it can include sciatica, radiculopathy, all of these things. In addition to that, joint issues. I see a lot of people with carpal tunnel, rotator cuff problems, knee issues, headaches, TMJ, different kinds of arthritis, fibromyalgia, and sprains, strains, and other kinds of injuries. There's definitely some things that you can help that are more systemic-based diseases, like functional constipation, some GERD issues, dysmenorrhea for women who have really bad periods. Dizziness, neurological stuff can include post-concussion treatment. And then I just want to focus on quickly the 2 special groups, pregnancy and pediatrics, because we are so limited by what we can offer some of these women, right? Back pain in pregnancy, pelvic pain in pregnancy, there's not many medications you can provide. Tylenol, even that at some points now is being considered, using as little as possible that you need to, sorry. And then pediatrics, I get some wonderful referrals here from our pediatricians for plagiocephaly, torticollis, and things like that. The caveat with both of these categories is the sooner you get them in, the better. And I know that my schedule's booked out 3 to 4 months, so please, if you have someone who is pregnant and is having pain, or a baby who's like 2 to 3, 4 months old and you're noticing they're having torticollis or plagio, call me, send me a message, I'll find a way to get them in the schedule. Because if we wait, it's not going to be as helpful for them. So since the predominant reason people see me is for pain, I just quickly wanted to go into a little bit about what we know about pain and what it is. The definition was recently revised in 2020 by the International Association of Society on Pain, and it says pain is an unpleasant sensory and emotional experience associated with or resembling that associated with actual or potential tissue damage. So there does not have to be any tissue damage for someone to have pain. And one of the important notes that they make on this as well is that pain is a personal experience that is influenced to varying degrees by biological, psychological, and social factors. And these are an example of some of these things. So here on the left-hand column, where it says stresses, these are different things that are impacting everyone's day-to-day life that might be impacting their pain response. So that could be stress at work, anxiety, relationship, family problems, history of injuries or accidents or traumas, history of PTSD, discrimination, racism. All of these things have an impact on how someone's body is going to be able to handle a stressor or a challenge. What it does is it sends a message to the brain. The brain is going to respond by triggering your autonomic nervous system, which includes your sympathetics and your parasympathetics. And then that sends a message to your body in how to respond. So that might be muscle spasms, right? Decreasing blood flow, which is going to worsen these muscle spasms. It's going to impact your GI system. It's going to impact your genitourinary, your heart system. All of these things can manifest as different symptoms in different people, depending on what they have going on in their lives. The issues that you saw on the previous slide can lead to pain without having manifestations on imaging. And there's been a lot of numerous studies done on how to correlate MRI findings with pain outcomes and symptoms. So this study was done back in '97. They looked at 20 to 58-year-old men, some who had never had back pain. Everyone got lumbar imaging. And they found that 45% had abnormal spines, although they didn't necessarily have pain. And then 47% who had pain had normal lumbar spines. So we're still not quite sure how to interpret some of the information that we find on imaging, because our imaging has gotten so good and detailed that we don't know how it translates to symptoms. I think it's just important to keep in mind that there are other factors contributing to pain, and in the absence of gross imaging abnormalities, the patient can still be experiencing pain and can still be helped by evaluating other things, which we're going to get to with what OMT does. So at this point, I'm going to go through a couple of these diagnoses that were listed at the beginning of the types of people that I see, and I'm just going to go through some of the research that has been done. I want to preface this with that osteopathic research has been growing for the past couple decades, but our quality of evidence is still low to moderate, and that's because we don't have big enough studies, we don't have enough power in our studies. But all of the studies and the systematic reviews that you're going to see here all see a positive correlation with benefit and recommend further workup, further study, and elucidating what's going on. So for low back pain, this was done back in 2005. And they found that OMT significantly reduces low back pain. The level of pain reduction is greater than expected, from placebo, and the effects can last up to 3 months. Another low back pain one, done in 2018, this was a review that also found that OMT is as effective as standard of care, including medications, PT, and other modalities for resolving pain and improving function in low back pain. NSAIDs are prescribed less frequently when back pain is treated with OMT, and OMT is also associated with reduced use of steroids and opiates and other pain medications. Also, they found these people had fewer days off from work and less days on limited duty. And then the final one, this is for non-specific chronic low back pain, done in 2020, and the review found that the results showed that osteopathy is effective in decreasing pain levels, improving functional status. And specifically, they looked at a couple techniques in this. Myofascial release, which is what MFR stands for, reported better level of evidence than some of the other interventions that were done. Next, we have headaches, and this was done in 2017. They found that it could most likely reduce the number of episodes per month as well as drug use. There's been lots of single studies done on headaches, both tension and migraines, that have showed decreased frequency, intensity, over-the-counter medication use, and improved physical functioning. This is an interesting one that was done on hospitalized pneumonia patients back in 2013, and they did a systematic review and found that OMT reduced the duration of hospital stay by 2 days and reduced the duration of IV antibiotics and total antibiotic treatment by approximately 2 days. And then pregnancy, pelvic and back pain. This was a Cochrane review from 2013, and they found PT, OMT, acupuncture, and a multimodal intervention, or the addition of a rigid pelvic belt to exercise seemed to relieve pelvic or back pain more than usual care alone. There was low quality evidence from single trials to suggest that OMT reduced pain and improved function, but there was moderate quality evidence for craniosacral therapy, improving morning pelvic pain and functional disability, and moderate quality evidence for OMT added to prenatal care in relieving back pain and related functional disability, better than regular prenatal care alone. Autonomics, which we briefly touched on with how our pain response is triggered in our body, right? So your sympathetic and your parasympathetic nervous system. There's been some really interesting studies done in this field where they show that there's significant change on the autonomic nervous system in the treatment of the suboccipital region. And individual studies have measured heart rate variability, sympathovagal balance after they purposefully stressed the participants to see what would happen. And those who got treatment fared better than those who didn't, and they actually had a lower spike in their cortisol levels with the stressor than the other group did. And then the bottom two studies also show similarity in increased heart rate variability, which is a sign of parasympathetic dominance, and toning down the sympathetic nervous system. So really important, because a lot of our patients here, the stress and trauma levels is one of the greatest in the country. And then finally, babies, there's been a few studies on babies. They did an interesting NICU prematurity study where they found that those treated with OMT had a reduced length of stay in the NICU by 2.7 days, and they had lower costs compared to the control group. There's been some reviews done on colic that show parents report less hours crying per day with the treated babies. And then plagiocephaly, I threw this in here since I know we do have quite a few of these babies, and I do end up seeing some of them. They have found in a pilot study that there's a 50% mean reduction in asymmetry in the 12 infants who had undergone a course of 4 osteopathic treatments. So, how does it work? It starts by examining the tissues, and by that I mean the joints, the muscles, the fascia, the bones, the organs, the whole thing, to determine where are the areas of restriction, where is there poor motion, where are the texture changes. And at this point, I want it to sort of involve you guys a little bit to do a demo, just so you can get a feel for how this works in your body. So what I'm going to do is have everyone stand up. And I want you feet straight, facing forward. We're going to start with our right foot. You're going to keep your heel on the ground, and you're going to tap this foot out to externally rotate, keeping your pelvis straight, and see how far it goes. So I stop here, and I get stuck, right? You might go only here and start to feel pain. Whatever it is, that's where you stop. Then we come back to the front. We do the same thing on the left side. So we're going to tap it out, and we're going to see, does this go the same amount as our other side did? I go much further on my left, yeah. So that means whatever side you got stuck on, that's the side that's more restricted. So you can have a seat. When I examine people, I find these areas of discrepancy, and then I will go and say, okay, this is the more stuck side. What's going on here that's triggering this? Is it a muscle issue? Is it a spasm, right? Is it some sort of an alignment? Is it a leg length discrepancy? What's going on? There's one more little example I want to do. If you guys don't mind pairing up, if there's someone next to you, just so you get a sort of feeling for what I do. You're going to turn, one's going to turn their back to the other, and I want you to just feel the trapezius muscle at the top. Yep, very gently squeeze, and you can sometimes feel one side Yeah, you may want to take off your coat. Yeah, one side might feel a little bit squishy or softer than the other side might feel a little bit hard or tender or uncomfortable. And your patient might actually feel it more than you do. Yep. And who doesn't have knots up here? And you can, if you wanted to take it further, if you just run your hands down the spine, you'll feel the difference in tension as you go down on each side. You can feel where those muscles are tight or soft. So again, those are the kinds of things that I look for, and then I help to treat out.
Is that related to the same limited range of motion in the lower extremity or not?
It can be. Yeah, and actually we'll get to that in just a little bit. And on that point, that's why it's really important to evaluate the entire body. And we're going to get to that for just a second to find out where something is coming from. So, we're still going. Okay, good. Okay, so to your question, Dr. York, a patient may complain of neck pain, but it's really being caused by a postural decompensation down in the pelvis. So that could be from poor posture. So if you look to the right of the screen, this is just showing you how it alters the curves of your spine depending on how you're standing. And that poor posture could be just from poor posture, working all day at the computer, sitting all day, etc. It could be from injuries in the past. It could be from a leg length problem, arthritis, other issues. Now, the compensation is going to transmit up the spine, up the curve, because evolutionarily, our bodies were designed so that ultimately our eyes are level. So if anything is crooked below, as you see in the skeleton, it's going to right the curves up until we get to the top. The patient might be feeling tension in the neck and coming to you for neck pain, but really they've got a pelvis issue that's triggering the whole cascade. So that's why we got to look. And so yes, it could be a hip problem that's causing a problem above. Similar to that, fascia is something that you may or not, be hearing about. It's big now in that they're doing a lot of research and finding it's not as passive as we thought it was. They have found that it contains contractile tissue and is able to actually impact the musculoskeletal system and the muscles that it is attached to. And I just put the picture up to the right. For those of you who may not know, fascia is that thin, white, sort of tough tissue that connects the skin to the meat in a chicken. And that covers all of our muscles and organs in our body. And they think that it sort of helps to transmit tension and forces throughout our system to keep things, moving properly. I want to do another quick little demonstration to show you how these are layers of fascia that run across the back, the front, sides of our bodies. And if you look at this one here, can you see where I'm pointing? No. So if you look at this one here, it's not hard to imagine this is your hip. How having a hip problem here can be transmitting up and giving you an upper back or lower back problem, right? If there's a line of tension being created there. And a nice way schematically to look at it is, though, if you imagine that my shirt is a layer of fascia that's covering my torso, if I were to kink up one side of it, right, create a knot, and I pull, where is that tension going? So I can work on your shoulder and your upper back all I want. Until I release this, you're still going to have ultimate problems. Does that make sense? Okay. So what does a treatment entail? My initial intake is a full history and physical exam. Each follow-up includes assessment and reevaluation to make sure that one OMT is still appropriate to conduct, that there hasn't been a worsening that would warrant further workup or imaging or referral to a specialist. And then these are followed by what I call the osteopathic structural exam, which is where I check all of these things that we've been talking about. And then finally you get to the part of the procedure of OMT. So as you can imagine, this takes time. And if you look to the right, to bring us back to where we started with what affects pain, the different levels of things going on in our lives, if I don't address these things with my patients, it's going to be harder for them to feel better. Because if they don't feel heard by their doctor, the ability to build a therapeutic relationship is going to be very difficult. And in my case, then, if I'm going to give them recommendations and they already don't trust me, they don't feel like I've heard what's going on with them, they're not going to take my considerations into account. So that for me might be demonstrating some stretches for them, some exercises that they need to do, discussing lifestyle, diet, smoking, sleep, stress mitigation techniques. All of that is part of the big picture as well. And then these are a list of some of the techniques that you may see in some of my notes used. I'm sort of just going to run through them so you understand what they are and have an idea of what it is that I do. In general, for the treatment, the patient is lying on the table on their back. It's pretty gentle contact by my hands on various parts of their body. Sometimes it can be uncomfortable if they're very allodinic or they have a lot of these tender spots or trigger points that we're also going to talk about. And I warn everyone that sometimes they can feel a little bit worse after. You can get a little achy or sore, and that's normal. It's also normal to feel completely nothing after. And it might take a few days for things to sort of settle down. It can also take several visits for things to start changing. And so it's one of these things where I recommend we give it a trial for about 5 treatments or so, and then we go from there and see if we're making progress and things are helping, we keep going. And if it's not, we say maybe we need to try something else. Maybe we need to do injections. Maybe we need to do PT or, other specialists. So the first one, the first few are actually the ones that I use the most. Balanced ligamentous or membranous tension. And I like to think of this as sort of a seesaw. And when your seesaw is perfectly balanced on that middle point, both sides are in harmony. So if we have a joint or a muscle spanning a joint that's pulling against it, and let's say one side is up, the other side is down, what I try to do is approximate them to allow us to get to that balance point, just to sort of give you a schematic. And then that allows for a release or a relaxation or a resetting of the area. Myofascial release is finding those areas of tight fascia and then applying some kind of pressure or sometimes like a twisting to help relax that area of fascia. Counter strain is very passive for the patient. What we do is we set them up in a position that shortens the muscle that's screaming and saying, I'm in spasm, and I can't let go. We hold it there for several seconds, usually up to 90 seconds, allow that muscle to finally take a break, relax, and then passively return them back to normal. Muscle energy is the opposite. It's very active for the patient. So I'm going to set you up. If your arm does not like to go up into abduction, we're going to go up into abduction as far as it'll go. And I'm going to have you push against me to activate those muscles to induce a resetting of the Golgi tendon organs in those muscles. And then high velocity, low amplitude is your cracking, popping techniques, which I don't do very much of. Articulatory is your low velocity. So what you're doing is you're sort of springing into a barrier, into a joint to help loosen things up. Osteopathy in the cranial field, I know, is very controversial. Essentially, the premise is that there's movement in the bones of the face and the neck, and by trading these out, you can help with certain problems. Facilitated positional release. You set someone up in a certain position, you add some compression or distraction, you take them through the opposite direction, and it usually helps to loosen things up in that joint. And then finally, a lymph pump, which is exactly what it sounds like. You're sort of applying a pump to the body over certain areas to help induce lymph flow. So great for people who have lymphedema, either in the lower extremities, upper extremities, in the chest. There's a sort of like a chest PT move that helps to break up if they've got upper respiratory stuff going on. All of these things are applied individually to each patient. So in one situation, I might use certain of them, in another, others. And then to round it off, the last thing I just wanted to mention is trigger points. So they are those knots that you feel in your trapezius where you push on it and it hurts. And for some people, it can radiate to other parts of their body. They're discrete, they're focal, they're hyperirritable. They're located in those tight bands of muscle. And like I said, they can produce the pain locally, but they also will radiate the pain to other areas. So your patient might be telling you, it hurts here when I push, but then I also feel it in my head. Or, lower in the back and I push and it shoots up my back into my shoulder. Those are trigger points. And you can attempt to treat them using physical maneuvers, but injections tend to do really well for these. And it's a very simple injection. It's lidocaine and saline. You go right into those points, like where those X's are on the screen there. You inject a very small amount, and it's both the action of the needle breaking into the muscle and the medication numbing it that seems to produce the result of calming it down and giving you longer lasting relief. So that's everything. And if anyone has any questions. Yes.
I do have one question. I'm unfamiliar with the terminology of morning pelvic pressure in pregnancy. And is that kind of equated to like an arthritic person, like that they have joint stiffness in the morning? I'm unfamiliar with that.
Yeah, I think they were just quantifying that they looked at a group of these women that were having their pelvic pain specifically more so in the morning. Yeah.
I have one question. Given the complex pathophysiology of migraine, I do understand how it helps with the tension headache.
Yeah.
Could you tell a little bit about the migraine?
Yeah, so there's been new research too that's showing that they think maybe tension and migraine headaches are sort of on the same spectrum, and that there's a component of tension that contributes to migraine causation. So I think it's along the same lines of decreasing that tension and improving the parasympathetics to help calm down the trigger of what's causing it, if that is a trigger that is contributing in that person. Yeah.
Thank you.
Would you give us a profile of your current patient caseload, maybe by gender, age, and referring diagnosis? What's your mix right now? What do you see?
So I tend to see women more than men. I would like to say they're mostly middle-aged to maybe older, around, 60 to 70. I do see some younger kids as well who come in for scoliosis and things like that, but that's a smaller proportion. Some babies as well, like I said, for torticollis or plagiocephaly, that's a smaller proportion. Most of the diagnoses tend to be, especially in this population, fibromyalgia, chronic pain, chronic arthritis. What else? I have a lot of people with spasms and trigger points. Does that answer? Yeah.
Can you, along that same line, can you go back to that slide at the beginning where you talked about all the different conditions you can treat?
This one?
Yeah. And then from those, are there anything that you think that we're missing? I know you also do general medicine and urgent care, that you think that we're missing in terms of referring to you as general practitioners.
I think the big thing is getting if there are pregnant women that are having problems, and getting the peds in sooner, just because the schedule's so full. So by the time sometimes they come to me, they're either like on their way to delivery, and that's pointless at this point, or the kids are so far gone down that road that it's going to be very difficult for me to effect a change, and they might need to escalate care and see more neurosurgery or something like that. So I think that's probably the biggest thing. I will say, if you have people, I don't see a lot of concussion people, and we're seeing some stuff that's showing that it can be helpful for that. So if you have kids who are undergoing some sports injuries and things like that, that would be good. That's probably the big thing.
Yeah, we see a lot of colic, constipation, reflux.
Yeah.
That's really common, but I've never considered referring to you for that. Can you explain a little bit about that process and how that helps?
Sure. So part of this is actually related to the fascias that are in your abdomen, and your mesenteries can, if you will, pull in one direction or another. So what tends to happen is that they will sort of pull down into the lower quadrants, either from the weight of the constipation. We don't know if something is setting it up, but we can actually help release that, sort of like if you've done abdominal massage on babies, or encourage the parents to do that for them, to help release the tension around there to allow them to go more easily. And then the other point to it too is the nerves that supply the motion and function to the colon. It located around T10, 11, 12 in the back. And so you can treat those areas to help induce a relaxation to allow more optimal function of the nerves that are coming out from there. Similar to like a piriformis syndrome, not on the same scale at all, right? But if you're having tightness in those areas and it's causing any sort of irritation to those nerves, it can lead to functional problems.
Is there an age range for any of those? It could be as young as an infant to
Yep.
a teenager?
Yeah, doesn't matter. And so the reason that I do urgent care is because I also did family medicine
Right.
as my initial residency, so that's why. Yeah. Yes.
So I'll just say that why like patients that I refer to you is it's funny that you say that about constipation. So I work mostly urgent care, and it's basically patients that are desperate. They're in desperate pain. They've tried everything. They tried therapy. They tried. So it's so funny that you mentioned the GI because I have a 4-year-old who's autistic, has rectal distension, was admitted to the hospital because basically the rectum has become almost a bladder, and the patient can't go to the bathroom.
Yeah.
She was discharged from the hospital. She couldn't go. She still was going to the ER. The mom was desperate. She doesn't want to take them back to the ER. So then here I am. I'm seeing them on the weekend. And I do an x-ray just to see how big it was. It was huge. Distended bladder, 4-year-old, nonverbal. I was pretty desperate. I'm just like, oh my God, what am I going to do? Do I send this patient back to the ER? The mom doesn't want to go. She got discharged. Was seen by GI multiple times. So out of desperation, actually, I massaged the lumbar area, did a general massage, try to remember from the recesses of medical school how much what I could do to relax the lumbar. But I knew the innervation tried to relax the lumbar. Afterwards, while I was talking to the mom to get the plan, I told her to massage the front and the back. And while I was talking to her, because he was still in her diaper, I could see this big ball of something filling the diaper while I'm talking to the mother. And I go like this, and the mom's just like, her eyeball popped out. He had the hugest, biggest VM, and we were done. So the funny thing is I didn't refer to you, but I refer back to GI, but this is a person that failed everything.
Yeah.
I've admitted multiple times, 4-year-old, nonverbal, and this is what it is, and it's just that works, so it was
Yeah.
like shocking. But the fact is, a lot of the patients that I refer to you are desperate people. They've gone through everything they could go through, and they still are having, whether a lot of times it's chronic pain, or actually chronic constipation, but you nailed it, constipation.
Yeah.
Really, of course, diet and exercise.
Right.
Works. But a lot of the moms, they're desperate. So I'd say I should definitely refer more of those patients to you, because they're definitely nonverbal, like innocent child, and so they don't have to spend the record that's going to affect them for the rest of their life. I mean, which is very important.
Right.
And then the other thing was also out of desperation, I see people that have really bad muscle spasm. And for example, somebody who's really just muscle and the calf is just spasm. She went to the ER, she gave her medicine, also like that more. But I just looked, and it was basically releasing the calcaneus, the patella tendon. And I showed the patient how to do it, and she was just so happy. So basically, this is chronic. You're giving the power back to the patient to affect their life. So I think that definitely there's movement towards patient empowerment and trying to give them the whole entire spectrum of care. So that's who I refer to you, basically, is the patients that are really, desperate, sort of,
Yeah, I appreciate that.
Yeah. Yeah. So.
Everyone's done. We're good.
Yeah, so thank you so much for these questions. And a couple things, as you notice, the lunch is not here. We ordered it for 11:30, and they said it's going to come a little bit late because of some accident. But we will deliver it to each of your offices, and apologize for the delay. And we really thank you for coming, and we're excited to continue these series of all the services that we have for our patients. And I know even talking about constipation and reflux, for in pediatrics, we know that the medicine is becoming controversial. So this is a more holistic option that we have for our patients. And of course, we know with the opioid epidemic rising, this is definitely something for a lot of our patients that have pain that we can refer to. I know she's very busy already, but she's always willing to facilitate our own patients as a priority to help and give care. So I really appreciate your time, and hopefully we can work together to improve our patient and our community. Thank you.
Hi, I'm Dr. Ruba Katrajian, and I just wanted to thank you for joining me today on our talk on osteopathic manipulative medicine. If you have any questions or would like to refer any patients, please shoot me a message in Athena. I hope you found it very informative and helpful. Thank you.